there will always be a way to transform a set of scores to get identical distributions. So there will always exist a way to move from self-report and get an identical distribution on a clinical assessment. So that being equal means and equal variances. So equal means being this notion of first order equity, and equal variances being this notion of second order equity. Keep this in mind because we're going to come back to those concepts. But that transformation will not guarantee equivalent scores for the same person. Okay? So the way that you'll know, you have a sense for whether or not those scores will be more or less similar within the same person will be if you've reached a point on theta, that's sort of the underlying PTSD severity, where both the self-report and the interview measure jointly have their maximum reliability. And keep in mind that we're talking about reliability that may actually depend on where in the scale you are. You know, those of you, like this is admissions committee season right now, so we're dealing with this sort of issue where, well, how reliable is the GRE? Well, it depends on where on the scale you're talking about. So, a couple different ways to get at linking. One is equating, and you do this with raw scores. So, you'll use different transformations of scores from one measure to the other by performing functions on means or the standard deviations, but what you see more commonly in educational testing is this notion of equipercentile equating. So you see this with SAT, ACT. You know, what scores correspond to the 75th percentile on the SAT, equating that to the same percentile on the ACT, okay? Well, what are some of the limitations on this? These are dependent on typically faulty assumptions under classical test theory, okay? And one of the things that I also notice that doesn't seem to be talked about in the literature is you're having to equate the summary score that you get relative to an entire block of items or symptoms. So your equating is dependent on having that whole set, okay? You'll see in a minute why that is also a limiting factor. It becomes advantageous to be able to do this at the item level. So the other way to do this is through what's called, at least in this context, item calibration. And I mean, calibrating items you do, it's done in a lot of different contexts. This is a very specific context called common persons or single group item calibration. So you're simultaneously estimating scale scores and item parameters, either via IRT or categorical, some form of categorical factor analysis, across both the self-report and the clinical assessment measure. What does that do? Well, output from this, you'll automatically get a combined scale score as output from both measures, and you'll see that shortly. And you'll also get item or symptom parameters. You can call them, refer to them as scoring weights. For your factor analysis folks, there's analogous to factor loadings as well as item intercepts. And you can use those to score just the self-report or just the clinical interview in ways that would reproduce the same distribution that you would have had. May not reproduce the individual scores that you had in some cases. But that might be fine depending on what you want to do. So what are the advantages? I'm not going to go over what the advantages are of IRT and categorical plenty of advantages and plenty of literature that talks about that. You're guaranteed virtually to have the same or similar distributions for each measure individually after calibration. After calibration, using both sets of items in the presence of quote-unquote missing symptoms. So I could create a clinical interview only measure treating the self-report as missing, or vice versa. Now, because we talked about this producing equal distributions, this is great for the equating of group level inferences. May not be as great, but there's some stuff that still could be done with individual scores. I won't get into that here. Now, what it allows you to do in general is, remember how before with raw score equating, you have to have a whole block of items to be able to do that? Here, it allows you to take pre-calibrated items, pre-weighted items, and mix and match to whatever you might want. This is how people create short forms. And by show of hands, who took the general GRE on computer? Did you ever wonder how, as you were taking the GRE, you answer the question, it gives you the next one? This is actually the same process that they use within the context of computer adaptive testing. So if you answer that one right, it throws it, in theory, it's supposed to throw a hard one at you, up until you get to the point where you stop answering. And the theory behind that is, you don't need to sit there for 3 hours. We can figure out and estimate what your score is after about 30 minutes, or even less in some cases. So that was that side of the literature. Had anyone dealt with this issue, generally or specifically within the context of the PTSD literature? Was there sort of a place for us to couch this educational testing methodology? What could we do with this? Or what part of the literature would benefit from something like this? Let alone had anybody else tried this. So, what was the state of the literature? Well, at a fundamental level, what are we trying to do, when balancing self-reported measures against some gold standard? We're trying to balance accuracy and assessment against burden on patients and clinicians. Okay, so the gold standard in PTSD measurement has been the CAPS. Now to the CAPS 5, Clinician Administered PTSD Scale. Used in a lot of different ways. Within RCTs, it's been used to establish inclusion criteria. And then you might give a self-report assessment during treatment, post-treatment. You might come back with this for post-treatment assessments. In primary care settings and specialty clinics, it's usually used to confirm a diagnosis after self-report, so depending on which context you're in, give a clinical assessment, then self-report, or vice versa. But it take up to an hour to administer this, okay? And so other than the time it takes to administer being a potential concern, so for example, if you're interested in doing an RCT with weekly assessments, probably not going to do this every week because it's going to overlap with the treatment process. And further, the clinical concerns about re-traumatization that come about as a function of the assessment itself. So contrast that against the utility of self-reported methods. PTSD symptom scale, self-report, IES, PTSD checklist, just to name 3. Well, people have actually looked at, in terms of comparison to clinical assessment measures, sensitivity, specificity, percent correct classification, receiver operating curves, all of this stuff in terms of looking at how well those measures correspond to clinical assessment diagnoses. And RCTs that actually have in-treatment assessments, particularly those that follow folks weekly, or even intervals that are more fine-grained than that, it's something that you see often. You're giving me 5 minutes, and talking about a lower risk of re-traumatization as a function of reacting to the assessment. But again, knowing what we knew from the work that had been done, as part of secondary analysis within CTN-15, I had in the back of my mind, well, doesn't all this presume that there's accuracy in assessment of self-report compared to whatever true value of PTSD severity is, let alone comparing it to the clinical assessment? And so it really begets a question of how accurate is accurate enough. And I sort of go back to that initial quote from Chen's work on equity, in that it shouldn't, go back to the principle of I should be able to get the same score regardless of which measure that I give you. But I already know that we're in a circumstance where that's, at least given the methodology we had at hand, that's not possible. So what are some of the consequences of this as a problem? They play out both in the screening and diagnosis literature and the treatment outcomes literature. So, for example, looking at the IBS, wildly different cut points in terms of determining whether or not someone might meet a diagnosis for PTSD. One study says 39, another study says 27. Same measure, different populations. Motor vehicle crash victims versus victims of crime. Now, what does that 39 versus 27 mean? Well, across multiple studies, you typically see a standard deviation of 10 for IBS total scores. So what are we going to do about a cut points that can vary by a shade over one standard deviation across populations in terms of determining whether or not they might meet criteria based on self-report? That seems problematic, okay? And then I alluded earlier to differences that can come up between clinical assessment and self-report measures within the same trial. Anywhere from 30% to 85% difference in the effect size coming from the same people. And again, this is not only unique, this isn't unique to us, but I don't think this is a unique problem across areas. So, what are some of the implied assumptions for PTSD measurement when we use total scores? Okay? Which is a hallmark of using scores under classical test theory. Well, one, they reflect an equal weighting of how each symptom manifests itself as a reflection of the construct or the disorder. And yet, in our own work, we've seen that, for example, trouble concentrating gets an equal weight, de facto weight of 1, compared to flashbacks or nightmares. When clinically, we know that these are probably symptoms that may actually weigh more seriously than some other symptoms of PTSD. Further, we presume that that weighting doesn't differ over time nor does it differ across populations. And in some ways, there's also this implicit assumption that there's perfect concordance across raters in order for total scores to be valid for them to work. Okay? These are circumstances that we will never be in, certainly not in clinical settings. And further, under classical test theory, scores that we estimate are dependent on the sample used to estimate the score. So you saw that with the previous example. These scores were never really meant to generalize across populations if the intention was just to use total scores. Whereas IRT, categorical factor analysis, calibrating under these models, it does two things. It puts cross-sample scores on the same metric, and further, it assumes scores are sample independent. How do we know that this is true? We talk colloquially all the time about GRE, SAT, other standardized tests, and we never bat an eye comparing, for example, my scores from 19, whatever it was, for example, to current, for those of you on admissions committees right now, versus current applicants to the graduate program. We don't bat an eye at thinking about comparing those scores across years, across cohorts, and what have you. And again, it's because generation of those scores, they're on the same metric, and they're not dependent on the sample from which they will be estimated. So, to go back to the fundamental questions that sort of underlie, what my summer reading list was. Is equating what I thought it was? It is. Had anyone really dealt with this notion of equating self-reported and clinical assessment measures? No, at least not in the PTSD literature. I did come across one paper that looked at this in depression. There are actually quite a few that sort of are interested in comparing that depression inventory to some other measure that they're looking to develop, BDI versus this, BDI versus that. It's not extensive, but there's multiple people out there trying to do something with this. And the one that was sort of most closely aligned to what I wanted to look at was actually a study from a group in Brazil, where they were looking to develop their own self-report measure for depression screening and norming it and calibrating it against the BDI. Okay. So again, what does a de facto model look like relative to classical test theory? All the weights of one for each symptom. Those weights don't change over time. They're not different across measure. This is essentially what we do with total scores. If we were to calibrate separately with IRT, we might get something that looks like this with 3 symptoms, where you might get some differences across self-report and clinical interview, some variation across time in terms of measurement properties. But these are really independently calibrated scores. This doesn't take into account anything in terms, so if you were to score these separately, that doesn't take into account any correlations across measures, and certainly doesn't take any correlations between the same symptom across raters. So you don't actually get symptom discordance at the symptom level cooked into your estimates. So what you would actually have to do is something along these lines, is actually estimate the scores all together. These would be the ways that you would get your gold standard measures.